This talk is about the estimation of the number of children with severe acute malnutrition in a population. We will start with two definitions. First, definition of prevalence. Prevalence is the number of cases of any given disease present in a population. It is usually expressed in percent. This is usually the figure you get when you do a classical nutritional survey. The incidence is the number of new cases you get in a population during a fixed period of time. Usually it is expressed in person per year. Now, the estimation of the number of patients to treat will depend on the type of disease you are considering. If you are considering the case of chronic disease such as diabetes, hypertension, HIV, the number of patients to treat is estimated by prevalence. This is the case because there are very few new cases every year and very few patients are cured or die. For an acute disease, the number of patients to be treated should be estimated by incidence. For instance, in order to know how many victims of car accident will be treated next year, an estimation of the expected number of car accidents in a year is needed. Counting the number of car accidents at any given time, as you would do in a prevalence survey, will give no relevant information. Now let's go and consider the practical question: how many children with severe acute malnutrition should be treated next year? So the method used to answer this question relies on different hypotheses relating to the epidemiology of severe acute malnutrition. The simplest hypothesis is to assume that you are facing a crisis leading to an emergency situation. So if you assume there was no SAM before the crisis, that the underlying causes of SAM have been eliminated and there are no new cases, and only children who are currently malnourished need treatment, so the number of children to treat is equal to prevalence multiplied by the under 5 population. And this method was used by NGOs before the introduction of CMAM. These hypotheses, assuming a clear crisis situation, are totally unrealistic. Actually, it relies on hypotheses which are never correct in practice. If there is some, usually there was some before the crisis, and the underlying causes of severe acute malnutrition cannot be eliminated in a few weeks, and there will be always new cases. The second hypothesis is to assume a chronic situation in which the underlying causes of severe acute malnutrition cannot be eliminated in the short term. In that case, you have to accept that new cases of SAM will occur regularly, and the number of children to treat every year will be estimated by the incidence multiplied by the under 5 population. When you start a treatment program in a chronic situation, another model has been proposed in which you introduce both prevalence and incidence. And what has been proposed is to calculate the expected number of cases to be treated in the first year by the prevalence, which represent the cases which are now present, plus incidence per year, which represent the cases which will be new cases for the year to come, and all this multiplied by the under 5 population. These methods, which take into account new cases occurring in the population and which rely on incidence in the calculation, are more reliable than models based on prevalence. Measuring incidence, however, is something which is difficult. To estimate incidence, you have two possible approaches. First, you can use a direct method, which is the reference method, which means counting new cases occurring all the time and estimating the total number of new cases in a year. The indirect method is based on estimating incidence from prevalence, and it is based on a mathematical relationship linking incidence and prevalence in a stable situation. And this relationship is incidence equal prevalence divided by the average duration of the episode of the illness. The direct method is not applicable when there is no system of case detection in place, which is always the situation when you start a program. So in that case you have to rely on indirect estimation. Unfortunately, this is very difficult, as only 2 articles describe an attempt to estimate the duration of an untreated SAM episode. The first article, which was published in 2009, was based on data from Sénégal and Congo. It is based on population surveys carried out in absence of treatment. Children were measured every 3 or 6 months, and data suggests that the duration of SAM in absence of treatment is about 7 months. In that case, this would suggest that incidence is equal to prevalence multiplied by 1.6. Problem is that the duration, the time between 2 measurements was rather long, and it is quite plausible that some episode may have occurred between these measurements. So this estimation of SAM treatment, SAM duration in absence of treatment, are not fully reliable. The second study took place in Niger and was published in 2011 by Isanaka and her colleagues. It was based on estimation of SAM duration of children who were measured every month. So this estimation seems more reliable than the previous one. This study took place in a setting where children were referred to treatment, and duration of untreated episodes were obtained by modeling episode duration of children who did not turn up for treatment by likelihood estimates. And the estimation of duration of untreated SAM was found to be about 45 days, which suggests a conversion factor from prevalence to incidence very different from the one previously found, as it suggested that incidence equal prevalence times 8. So in this process, some lessons were learned from attempts to measure incidence by indirect method. Actually, these attempts show the limitation of this indirect method to estimate incidence based on prevalence data. First, conversion factors from prevalence to incidence are highly variable from one study to the other. Other problem is that the hypothesis of a stable situation is rarely true. Some prevalence estimates themselves are imprecise because surveys are not really adapted to calculate the prevalence of severe acute malnutrition. It is more adapted for estimating prevalence of moderate or global acute malnutrition. But severe acute malnutrition is, statistically speaking, a rare condition which is difficult to capture with the kind of sample size used in current surveys. And also another problem is that prevalence surveys are often based on weight for height, while admission for treatment are also often based on MUAC. So this leads to many discrepancies. The limitation of this indirect method to calculate incidence should encourage us to use direct estimates of incidence. Actually, the situation changed since 2009, when measuring incidence from prevalence data were first proposed, because at that time there was absolutely no other way to know how to measure incidence. But now there are many settings where treatment programs have an active case finding component which allows a direct measure of incidence. And when there is an ongoing program, the number of cases can be estimated by the number of treated cases divided by the coverage. National data as those produced by Niger can shed new lights on how to interpret results of nutritional survey. So this table shows you the estimated number of children with SAM as estimated by prevalence survey in the second column. And you can see with a prevalence of 2.6%, this suggests that at any given time the number of children with SAM will be almost 89,000. But if you look at the fourth column, in which is entitled Estimated SAM Burden Number 1, which is based on admission data corrected for coverage, you can see that the number of children who get SAM every year is something like 800,000 children, considerably higher than what was obtained from prevalence survey. And interestingly, this figure is very close to the figure shown in estimated SAM burden column number 4, which is on the last column on the right, which is obtained by using prevalence multiplied by conversion factor of 8.1 as suggested by the Isanaka paper, and which found an estimated burden of 800,000 children as well. I think this table is illuminating, showing the limitation of interpreting prevalence data without using an appropriate correction factor, and showing how estimating admission numbers corrected for coverage gives a very good estimate of the picture. And I'm pretty sure that this kind of data will become more and more frequently available in different countries and will give a more correct picture of the burden of severe acute malnutrition. The national data, however, are difficult to collect with a high quality level, and may somehow be unreliable to make good estimation of SAM burden. And an answer to that may be to use Sentinel site with data quality improvement system, and which can be used to reflect variation in the SAM burden from year to year. In conclusion, estimating the number of children suffering from severe acute malnutrition every year is difficult and has many uncertainties. Using indirect method for estimating incidence based on prevalence only helps in situations where direct measurements is not possible. Direct measure of incidence, ideally from well-controlled Sentinel site, will give better estimates. Also, using data from previous year helps to estimate the number of cases likely to occur in the following year. I hope that with a better estimate of incidence, the real importance of severe acute malnutrition as a disease which may potentially kill children should be better estimated.